Hello, my name is Rhett Reber and I am presenting a case study for 9 November 2010. I am currently a Texas Physical Therapy Specialist in New Braunfels in the Army Baylor Doctoral Program for Physical Therapy. The case that I'm presenting today is about a patient that I saw in October of 2009, a male, 33 years old, rancher, while I was at Randolph Air Force Base. His main exercise was physical labor on the ranch, and mechanism of injury was falling off a tractor onto right side and shoulder. P1 and P2 are seen here. P1 mainly AC joint and surrounding area. P2 is right thoracic spine. P1 was described as being an ache with some sharpness, intermittent but variable. Aggravating factors were shoulder flexion, coughing, and sneezing, brought it to a 6 out of 10, and easing was just limiting range of motion in the right shoulder, and that brought it down to a 1 out of 10 in 10 minutes, and symptoms were stable. P2 was described as a discomfort, but fairly painful, as I remember, and intermittent but variable. Aggravating and easing factors were the same as P1, and those symptoms were stable as well. Also, coughing and sneezing brought on both P1 and P2, and the patient thought that P1 and P2 were related, especially with trunk movements or coughing and sneezing. He said actually that moving and standing made his symptoms better and sitting made them worse, with best symptoms during the day, worst at night. Other aggravating factors were bending, squatting, walking, sudden movements, or pivoting. His photo score was not taken due to the clinic that I worked at. Medical screening questionnaire, he had no past surgical history, and he was only on ibuprofen. He had x-rays and MRIs. Currently having symptoms in his back and shoulder, which started 1 month ago with the accident suddenly, and they seemed about the same to him. He'd been treated with a sling and medications. He had an accident similar to this years prior. He couldn't remember the treatment that he had and how it made him feel. Currently he was having moderate difficulty sleeping, and his goal was to have no more pain and more movement. He had no barriers to learning. He had no significant past medical history, and he was currently not experiencing any of the following special questions. After subjective, primary and competing hypotheses were as follows. First and foremost was AC sprain with thoracic spine and mechanical fault, or dysfunction. Competing hypotheses were cervical radiculopathy, rib dysfunction, primary care, to include lung and heart pathology. My objective was first observation of the thoracic spine and right shoulder. Patient was guarding the right upper extremity with significant AC deformity on the right side, mild swelling, no ecchymosis, and a kyphotic T-spine. Active range of motion was limited in mostly abduction and flexion. Abduction brought on P1, flexion brought on P1 and P2. Thoracic rotation left and right brought on P1 and P2 with 4 out of 10 pain. Manual muscle testing, he had 5 out of 5 upper quarter, except for right shoulder flexion was 4 out of 5 with P1 and P2 brought on. Neuro was intact and equal bilaterally. Special tests, negative quadrant, upper limb tension test was deferred due to instructor preference. AC shear brought on P1 at 2 out of 10 pain, and he had a negative cross arm adduction. Joint integrity and mobility, the AC joint was hypermobile and painful, which only brought on P1. with a 3 out of 10 pain, and he had positive T-spine PAs, T3 through 6, and positive tentative palpation, rhomboids, and right AC, 2 out of 10. Also included in the objective would be his x-rays. This is not his x-ray, but his was very similar, with a distinct separation and deformity present and no fractures present. So was my hypothesis confirmed? Let's take a look first at the local findings for P1. Yes, he did have AC dysfunction, decreased range of motion with local pain, and radiographs definitely showed the separation. But combined with the findings of P2, he had thoracic range of motion limited, and which brought on painful P1 and P2, and a thoracic PA brought on P1 and P2 as well. So my conclusion, adding both of those together, was that there was a definite thoracic spine dysfunction bringing on most of his pain. P1 did equal P2, which brought him to the manipulation mobilization group and postural exercise group. Conclusion, also the primary care could be ruled out for now due to mechanically reproduced symptoms, negative x-rays, and negative special questions. Our treatment consisted of the following: manual therapy and home exercise. For the therapy, we did prone thrusts, T3 through 9, with a home exercise program to include postural education and thoracic mobility exercises. And post-treatment effects were as follows: flexion increased, P1 and P2 onset at 100 degrees originally. Post-treatment was 150 degrees, and he had no resting pain. So he said something to the effect of, "You cured me, doc." 1 week later we followed up, and he reported that he was feeling great with some soreness and very little pain since. He had some local tenderness that week at the right AC. He was able to put his shirt on and go back to work. Range of motion was consistent with post-treatment effects, so he had not regressed at all, but had continued to improve, and he was compliant with his home exercise program. So the plan then was to discharge him to home exercise program. His symptoms were under control, he had less pain, and he was very independent on his home exercise. This concludes my case study for the Texas Physical Therapy Specialists.